I'm going to take this at a reasonably leisurely pace because I think it can be quite tricky, but I will promise that I will finish on time at 2:45. I'm going to stand back a little bit from there. So, I'm from New Zealand, but I've lived for 32 years in London and just came back last year. And one of the things that I noticed when I came back was that when you went to a talk in New Zealand, people like to sort of reveal something about themselves. They like to show a photo, and usually it's some sort of sporting photo, them after they've sort of ridden up Mount Everest in 20 minutes, looking very sort of fresh. So I think it's sporting. So this is me in 1982, about to go mustering some sheep on a farm near Waimate. And I can assure you that it was a PDSA cycle of 1. I never ever repeated this experiment before again. So, though theoretically this seems like something which is quite easy, all you have to do is do a PDSA cycle and the world will be cured, it is actually much, much harder than that. And having worked extensively in quality improvement, I can assure you that life is never as simple as a PDSA cycle diagram. Why is it harder than it seems it should be? So I'm going to show you 3 pictures. Okay. Does anyone recognize the picture on the left? Yeah, it's New Zealand. On the left, it's the New Zealand High Commission in London. It was built in the early 1960s. Okay. The second building is slightly more obscure. It's the Royal College of Physicians in London on the edge of Regent's Park. In the 1980s, those 2 buildings were regularly voted the worst buildings in London. Yeah. They were considered to be complete eyesores. The New Zealand High Commission was built on a hotel that had been bombed during the Second World War, and New Zealand built it as an example of modern architecture, bright, a nation that was sort of finding its way in the world, that was asserting itself, that was new and dynamic, and they situated it next to a whole load of 18th century buildings. Okay. The Royal College of Physicians sits on the edge of Regent's Park next to large Regency terraces built in the sort of mid-1830s. Okay. By the year 2000, both of those buildings were considered of historical importance and were listed by English Heritage as Grade 2 listed buildings, which can't be altered in any way. So the last one, someone I think recognised it as North Shore Hospital, was built in the early 1980s. And I worked there briefly as a house officer in 1986. And I remember a surgeon taking me to one side and saying, "You realise that this building is a complete folly. It's that George Gare wanting something for his constituents on the North Shore. It's never ever going to be of any use," yes. And when it opened, I worked in the emergency medicine department, and it shut at 10 o'clock in the evening and opened again at 8 in the morning. I was pleased to see in George Gare's obituary from a couple of years ago, he was now being described as a man of great vision. Yes. He clearly had seen a need where no one else had seen it. What is my point? My point is that things change, yes, but the culture that you're working in really shapes everything. Culture can change, people's attitudes can change, but it's a slow process, okay? And it's that cultural context in which you're working which can make things more difficult. Some organisations take to this better than others more quickly, okay, but everyone can get there in the end. Okay, so we're going to run through an example. So Imagine we work for Western Hills Healthcare. I chose this name because no one, as far as I know, has got the word Western Hills in their name, so I'm not picking on anybody. And their motto is serving our community, okay? And it's a modern organisation, so it's got 2 CEOs job sharing. Mary, who's been a chief operating officer previously, so we know what she might be like. And Drew, who's been a chief nursing officer, okay? They've got 500 beds, 40 mental health. They've got 500 key performance indicators that they're trying to meet, yes, so it's a pretty typical organisation. And mental health has 105% occupancy. Many people will be familiar with a scenario pretty close to that, okay? And now, the media are onto it, okay? Teen mental health patients put on adult wards in bed shortage, all right? That is a CEO's nightmare. And I have noticed actually since I've been back that actually local press can be quite ferocious. So some organisations really get a hard time in the local press. So, what should they do? Well, they can focus on the process, they can focus simply on the outcome, or you can focus on the system. And I'm going to just run through what happens when you do some of these things. So if you focus on the process, you can do that, yes? You can colour everything green, apart from the bit at the bottom which they missed, all right? And that will reassure people, okay? That will reassure people that stuff is going well. Whether it's true or not is another thing. And one of the reasons I show this is because that was the RAG-rated document that reflected the quality of the care that was being provided in an organisation that I worked in London 2 days before it had the worst patient safety event ever. Okay, a patient killed another patient on an inpatient ward. So, people look to that style of thing for assurance, but I would suggest it doesn't provide the assurance it needs. You can focus on the process, and what you can do is you can wag your finger at people, okay? And you can say, you can call in the managers, yes, and you can focus, you can pull people into your office and you can say, this is not good enough. Yes, we need to focus on this. Okay, we need to get this sorted. Okay, and you can get them in the next day and you can say, it's still not good enough, okay? And you probably, by bullying and harassing people and making them feel miserable, you can probably get a temporary improvement in what you're trying to do. But I can assure you, it will not last, okay? And one other of those 500 indicators that you're trying to focus on will start to deteriorate and you'll be calling people in to look at the next one, okay? And it is a bit like playing that game whack-a-mole, okay? The mole pops up, you get a hammer, you whack it, yeah, and then something pops up over there, okay? And if you're running an operation like that, you are not onto a winner. Okay. So why we're doing this, why we're taking this approach towards quality improvement is because we want something sustainable, different, that doesn't leave staff feeling bruised and worn out and harassed by the end of it. So, the evolution of improvement science. We're not going to go through, I'm not going to test you in detail on this, but the important thing is that this science didn't start in healthcare, it started in engineering, okay? And I know what you're thinking, engineering and healthcare are not the same, and that's unquestionably true. However, there are a lot of similarities between them. So, Walter Shewhart was an engineer. Edward Deming's very important. He did a lot of work in Japan post-war, improving their industry after clearly a devastating war that they've been involved in. And out of all of this came the model for improvement, which was adopted in healthcare now sort of well over 20 years ago, okay, and his theory of profound knowledge. And basically, what they're saying is that you need to have a really good understanding of the system you're working in order to produce a sustainable improvement. Okay, not just focusing on your bed occupancy, the number of falls you had last week, or whatever, your sickness rates for staff, yeah? You need to have an understanding of the whole system if you're going to make a change. And so there are 4 components to the system: human behaviour, the variation in it, your theory of the system, and the appreciation of how it works. I'm going to take you through those 4. All systems have variation. Your bed occupancy today will not be your bed occupancy tomorrow, okay? Will not be your bed occupancy the day after. The number of falls you had yesterday will be not the same as the number of falls you had today. There'll be a different number of falls the day after. What you've got to understand about that variation, though, is whether it's common cause variation, which is just variation, it's just the system doing what the system does, okay, or whether it's something exceptional that's changing in the system, okay, that's telling you that something has altered. And I'll give you an example of this in a minute. You've got to be able to understand and predict what your system is going to do. Okay, no surprises. You've got to be able to predict what's going to happen next week, the week after, okay, based on your knowledge of what the system is doing. You've really got to understand the people involved in the system, and people underrate this. At the end of the day, most of a hospital healthcare system is about the people in it. Okay, it's about the staff, patients, service users, consumers. And if you don't understand human behaviour, or if you pretend that you can just take human behaviour out of the equation, then you're in for what I think is probably a quite sad experience and probably not going to be successful. I'll give you an example of this, which is a good reflection of culture as well. We had a problem, which is common in mental health services, of patients deteriorating without the deterioration being detected or acted upon. So patients on an inpatient ward, they're getting sicker and sicker and no one is doing anything about it. And they may or they may not be taking regular blood pressure, temperature, pulse recordings, but if they are, they don't do anything. So we took something that had been used in acute care, a colour-coded chart, in which, Muse chart, in which you could clearly see whether the person's pulse rate, for example, was in the green or the red, the blood pressure was in the green or red, and you could clearly see deterioration. And we thought, naively, and it's quite some time ago, that we probably had cracked it because we now had a way of easily charting people's recordings so that anybody could see that it was getting worse. What we hadn't counted on was the fact that the chief financial officer had decided that we were printing too much in colour and had made the default on the printer black and white, okay? And I came in one Monday morning and I had a sort of fairly feisty senior nurse that ran the physical healthcare who slapped the Muse chart down on my desk and said, "Look at this." And she said, "It's in black and white." Yeah, so all the work that we had done, okay, had been undone because actually you couldn't use the chart if it's in black and white, okay? So it just goes to show that if the organisation is focused on saving money, then people will do lots of things which will save money, including stuff which is actually going to make things more unsafe for patients. Why change? Because if you always do what you've always done, you will always get what you've always got. And even though we know this is true, there are loads of examples, aren't there, of people trying to do the same thing over and over and over again in the hope that somehow things will improve. And as another example of this, when I worked in London, we were the third worst trust in the United Kingdom for flu vaccination rates. And our flu vaccination rate was 17%, okay? So 83% of our staff refused to have flu vaccine. Despite that, and despite the fact that we were shamed every year, the HSJ ran its article saying we were the worst mental health trust for it, we did the same thing every year, yes. And it wasn't until someone said, this is just ridiculous, why don't we do something completely different, that actually we've got to change, okay? But had that person not come along, I'm pretty certain we would have had something like 17% the following year, because we would have just done it the way that we'd always done it. So, the fundamental improvement questions. You have to be really clear about what you are trying to achieve. You have to be able to clearly describe your aim, okay, and objective, and that has to be understood by all the team that are working with this, okay. I hope that things will be better next week is not a clear aim, okay. Indeed, hope is not a plan, okay. It's just a hope, okay. So can you clearly describe what it is precisely that you're trying to do? How will you know that change is an improvement? What are you going to measure? And I know you've got a session this afternoon on measurements, so I'm not going to say too much more about it. But you have to be really clear about what you're measuring and what changes are you going to make that will result in an improvement. What have others done? What hunches do you have? What can we learn as we go along? You have to be permanently inquisitive and curious. Okay, assume nothing, I always say. Don't assume that it's going to work, sort itself out. It won't. So this is the actual model for improvement. So what are we trying to accomplish? How we know that change is improvement? What changes can we make? And then the plan, do, study, act, cycle, which I think probably many of you are familiar with. Small change, that's really important, okay, that the PDSA cycle is about small scale change. It isn't massive, yes. You are making a tiny adjustment to how you're operating and then seeing how it works, measuring it, thinking again about what you're going to do, okay. I have seen some quality improvement projects in which people are doing 3 or 4 PDSA cycles a day, okay. If you are doing a PDSA cycle every 2 months, okay, you have a systemic problem, okay. That is not what this is about. Small scale, rapid change. What people tend to do, or what quite often people do, and I've been guilty of it myself, is to wait until you've got the perfect conditions and you've thought it out perfectly and you've spent a good 6 months studying it before you actually try to do something, okay? That's not the way to do it, okay? There is no perfect moment in time. You will never have all knowledge, okay? There will never be the right number of staff, the perfect number of staff in your ward to do it. There will never be a perfect time in which suddenly there is like sort of a 2-week gap in which you don't have to do something else, okay? You sort of have to get on and do it. And the more you do it, the easier it becomes. So, it's structured, small incremental changes to systems. And there's a full cycle of planning, okay? It should be easy to understand and common sense. And actually, people don't like change. People just sort of, there's a comfort in what you know, even if it's not sort of delivering what you want. There is a comfort to be had from knowing that sort of tomorrow will be like today, will be like the next day. But again, that's not what it's about. This is about having a way of making change which everybody understands. So I'm now going to show you an example. Okay, so this is from East London. So this was around violence reduction over 4 acute wards, okay. What I will say, I was chief medical officer at the time, and the staff came to me, and we'd done this QI training, and they said they wanted to work on violence reduction. And my heart sank, yes. As the first thing that you'd want to do, violence reduction on an adult inpatient ward, because I was convinced that this was never going to work. Yeah, people would just become disillusioned, and we'd be moving on to something else, okay. The nursing staff working in the ward were convinced that they could do it, okay, and they were right, and I was wrong, and proud to be wrong, actually. They started on 1 ward, they did it on 2 wards, and then they did it on 4 wards. So this is at the 4 ward stage. Okay, yeah. So this is the data before the change, okay, and the first thing you can see is that it goes up and down and up and down and up and down. That's the number of incidents per 1,000 occupied bed days, which is probably not a metric we'd use nowadays. But anyway, we used it at the time. Okay. So the system has a lot of variation, okay. The number of incidents you have that day is not the same as the number you have that day, okay. It's very easy to get into a trap of thinking it's getting better, it's getting worse, oh, it's getting better, it's getting worse, it's getting better. It's not doing any of those things, okay? It's just doing what it does, okay? This is normal variation. And then they started their QI work. Now it seems like, oh, they did a number of things and sort of things got better and that was really easy. It wasn't. It was really, really hard. People required a lot of support. It didn't always work. People became disillusioned. One of our greatest champions for this project was a unqualified healthcare assistant who actually had been quite badly assaulted by a patient and had spent a month off work, and she didn't want to come back to work back to an environment in which violence was accepted. And she did, she was a great advocate for this work, but she did a number of things which, quite unconventional. So she's decided to get people engaged by offering fried chicken to anybody who sort of completed 4 PDSA cycles in a week. And that proved to be very, very successful, okay? And that's the human behavior bit of it, yes? Humans are motivated by different sorts of things, and she obviously had a better idea as to what was going to motivate people than I would. There were a number of learning. So the safety culture bundle was started, the number of learning sets. People got together, they shared ideas, they talked through what was working, what wasn't working, agreed to try stuff out. They introduced safety huddles. They set out, things went smoke-free, so people will tell you, if you go smoke-free, you can expect the violence to go climbing right back up, but actually that didn't happen, okay? And as you can see, they got a 57% reduction, okay? They got a 57% reduction and sustained reduction, just by using the methodology, thinking about what makes people tick, and sticking with it, okay? I'm probably out to prove me wrong. That Who knows? Okay, but they got it and they achieved it and it's been sustained. So that's a good example of stuff that works. Let me just show you another example, which is probably of something of a different type. So a car has gone into the water off this wharf in Scotland. They're picking it up. They're picking it up, and over it goes. Okay. There we are. Okay. PDSA cycle 1, not successful. All right. PDSA cycle 2. They get a larger truck in. They get the car out. They're now going to retrieve the first truck. Here it comes. Yep, you guessed it. Okay, PDSA cycle 2. All right, it's all right to fail. Okay, indeed, it is extremely unlikely that you will be successful the first time you do it. Indeed, I have never seen a sort of one PDSA cycle, ta-da type situation. All right. Okay. So, just and final. So break it down into small manageable chunks, not audits, okay? It can't be too small, it can be too big. All right. Just carry on with your small changes and then you can test it out across the whole system. Tell people what you're doing. It doesn't work, yeah? But if you're going to fail, please fail quickly. Don't spend 9 months failing, okay? Just try it once, try it twice, doesn't work, move on, okay? It's fine. It's good to fail. That's how you learn. Okay. Thank you. Questions?